Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
It's 2:15 a.m. on a busy overnight shift. The waiting room is full. Paramedics roll in a 24-year-old woman on a stretcher, curled on her side, pale, diaphoretic, clutching her lower abdomen. She tells you that this pain feels just like the two last times she was in your emergency department, once 3 months ago and once 6 months ago, but this time it's much worse. She's vomiting, non-bilious, non-bloody emesis. She's having difficulty standing upright. She says her menstrual period started this morning and the pain ramped up very quickly over a few hours. Her vitals are the following: heart rate, 118, blood pressure, 108/64. She's afebrile, respiratory rate is 22, and her oxygen saturation is 99% on room air. She tells you she's had bad periods since high school. She missed school, she missed work, and she's been told she has ovarian cysts. Last ED visit showed a small hemorrhagic ovarian cyst on ultrasound. She was discharged with NSAIDs and told to follow up with gynecology. She unfortunately never got that appointment. She doesn't have a family doctor. You're thinking about what to order. You order the usual tests. Her beta-HCG comes back negative. Her CBC is normal. Urinalysis is clean. And the pelvic ultrasound again shows a small cyst. No evidence of torsion, no free fluid, no acute surgical pathology. The pain, however, is still 10 out of 10. You're now standing at the bedside with several questions running through your head. Is this just another flare, or am I missing something dangerous? Is it safe to discharge her again? How aggressively should I treat her pain? Do I start hormone therapy? Do I get a CT? And most importantly, am I helping her or just cycling her back into the same broken system? So to help us answer these questions and many others, we have the mighty return of SHREMI's Deputy Director, the Medical Editor of the Canadian Medical Association Journal, EM clinician scientist from Sinai Health in Toronto, a fantastic speaker on the EM conference circuit, my friend and colleague, Dr. Catherine Varner. Welcome back to the show, Catherine.
Thanks for having me, Anton.
And new to EM Cases is Dr. Jennifer McCall. Welcome, Jennifer.
Thank you. Thanks for having me.
Great. So can you just tell me a little bit about your professional background and how you got interested in endometriosis management?
Yeah, so I am a minimally invasive gynecologic surgeon, and I've done a subspecialty fellowship for 2 years in surgery for endometriosis, as well as the medical care of people with endometriosis. And in my fellowship, I also got some training in chronic pain. So I fell into that fellowship because I really love complex surgery, but I also love the patient population that we get to treat when we do that type of training, which is a lot of people who've sadly been dismissed for a long time. They've had years and years of dissatisfying experiences with healthcare. And then when they finally land in the right place, you really feel like you can listen and you can help them. And that's what I find so satisfying about doing subspecialty endometriosis care. So I was a general gynecologist by training, and then I did my 2-year fellowship, and that's what I'm practicing in now.
So it's important to mention that this podcast is a collaboration with both Health Canada and the CanSage Endometriosis Care Program, and it's to help raise awareness for medical professionals to recognize and manage endometriosis, to bring together ED docs, gynecologists, and family doctors to better the care of patients living with endometriosis. And before we get into the nitty-gritty of things, Catherine, Jen, do you have any conflicts of interest to declare?
As mentioned, I'm the deputy editor of the Canadian Medical Association Journal, but I don't have any other conflicts to share.
I receive honoraria from AbbVie, which has some gynecologic products, and I'm a contractor with the Department of the National Defense.
So let's talk a little bit just about this case that I presented, this 24-year-old with severe pelvic pain. Catherine, what are your just sort of general thoughts before we get into the nitty-gritty of it all?
So I know that this type of patient presentation will result in a long journey in our emergency department. So this patient comes in at 2:00 in the morning. I'm sure that I won't see the results of the ultrasound potentially until mid-morning. So it may actually be well after my shift is done. And I think that's one of the challenges of this patient population is that they sort of lose the continuity of care with their emergency department provider from the time that they come in to the time that they're discharged, or when you're getting these results back. And what's most concerning for me now that we have these results back, her beta HCG is negative. The ultrasound reportedly only shows a hemorrhagic cyst. She's still in 10 out of 10 pain. And I don't have a clear answer for why that is. And so, thinking about pelvic pain, 10 out of 10 pain, that's now many hours later not treated and not managed, I'm worried that we're missing something. So what are we missing? Is it possible that she has an ovarian torsion? Is it possible that she has a non-gynecologic cause of her pain? Those are going to be front of mind when I'm reassessing this patient.
Absolutely. Like, I would not be sending this patient home with this 10 out of 10 pain. As we know, ovarian torsion can be missed on ultrasound. It's more of a clinical diagnosis. And that would be kind of my primary main diagnosis in the differential at this point is an ovarian torsion. And that's what we're good at in emergency medicine, is figuring out the really bad, dangerous, life-threatening things. Dr. McCall, what are your sort of just general thoughts about this 24-year-old with severe pelvic pain?
I hear this story and I think of, seeing this patient probably 2 years later and hearing this story in retrospect. That's the most common way that I get to hear about this patient, is hearing about their emergency visits in the past and all that they've gone through before they've arrived at my door. And I feel for this patient. I feel for the fact that, like Dr. Varner said, that this is a long journey, but I'm not thinking just the hours this time in the emergency. I'm thinking of the months and years that this patient's probably going to endure before she gets the care she needs, and how it can be so disheartening for patients to have this experience where, sometimes to patients, all doctors, all MDs are equally experts in all conditions. And so they feel so disheartened when they've seen, in their opinion, multiple doctors, or from their perspective, multiple doctors, and never received a diagnosis. So that's one thing I think about, is this patient who I feel for her suffering. And the other thing I think of is how difficult it is for patients to walk away without a diagnosis, even though that's sometimes actually better for them to be told the diagnosis in your case, if we don't find anything else, is pelvic pain. And, hopefully, and I will refer you to someone who can help care for your pelvic pain, because sometimes I spend a lot of time undoing diagnoses that given to patients that are incorrect. And I can't count the number of patients I've seen who've been told that they had an ovarian cyst rupture and they come to me asking for their ovaries out. And in fact, it's not that they had an ovarian cyst rupture, but that was a diagnosis of exclusion given to them in that moment to give them a glimmer of hope of a diagnosis. But those are two divergent thoughts that I have about this patient's suffering.
Yeah, I have to say, guilty as charged.
Totally.
I mean, I've told many women that I've treated in the emergency department that the reason they have pain is because of their ovarian cyst or ruptured ovarian cyst or hemorrhagic cyst, when I'm not exactly sure of that, and they just want a diagnosis. So I think that's a really important point, that it's okay to tell patients your diagnosis right now is pelvic pain, but we're going to get you help to sort it out further.
And, obviously sometimes people do have ovarian cysts rupture. And I think when there's good evidence of fluid in the pelvis on imaging and the timing coincides with ovulation and their pain resolves in a, subacute fashion within a few hours and responds to NSAIDs, that is a diagnosis that can be given. But the most often time I see it is that it's a presentation exactly like this patient, nothing on imaging, or a small cyst on imaging, no free fluid in the pelvis, a cyst that maybe is there on multiple presentations, and just cyclic presentations to the ED. And that's kind of what they get told. So not to say it's never the correct diagnosis, but yeah, I think pelvic pain as a diagnosis is totally an appropriate thing.
Yeah, great. So we're going to touch on a few of these themes, like the loss of continuity of care and how to actually make the diagnosis in the emergency department, or being careful not to make them a diagnosis, and then what to do. But before we jump into what to do, we need to understand why they're there in the first place. And I think we've kind of sort of touched on this already, but I want to get a little bit more into it. So why do so many people with endometriosis end up in the ED? Jennifer?
Sadly, in our Canadian system, and I'm in Quebec here, and I know you're in Ontario there, but across the country, the wait times for gynecologic outpatient care are extremely long. So that is one piece of the puzzle that is sadly leading people to end up in the ED when they don't have an outpatient gynecologist or family doctor who's comfortable managing that kind of care that they can connect with and that they can access easily. So that's one significant issue for sure. In addition to which, there are also a lot of gynecologists who aren't comfortable managing endometriosis and chronic pain. So that can be another barrier for patients, is that they can get referred to general gynecology. And then counter barrier is if they have a provider who's not that comfortable with endometriosis and chronic pain. Other things that come up frequently is that the patients, when they have such severe levels of pain, one of the first things they do is turn to Google, and Google says, if you have severe abdominal pain, you have to go to the emergency room. It could be one of these 10 life-threatening things. And so people go to the emergency room over and over because they haven't learned yet, until they've been connected with chronic pain care, they haven't learned what is a pain emergency and what is a flare of their usual pain. And so they're worried that they are going to, come to harm if they don't seek emergency care.
Yeah, if Dr. Google was a person, I would really want to go out for a coffee with Dr. Google and have a long conversation.
I do think that when patients have 10 out of 10 pain, very appropriate to go to an emergency department. Where else can you have that degree of pain treated in real time? And I think in our field, when we hear endometriosis, we don't think of it as causing 10 out of 10 pain, but it absolutely can be a cause of severe pain that needs to be treated with intravenous analgesics, because they can't take oral pain medications because they're vomiting. I mean, it can be quite severe.
I want to get into a few numbers. So how often do these ED presentations, how often are they truly flares versus delayed diagnosis versus complications of endometriosis, which we're going to get to, because when we talk about dangerous diagnoses, most emergency doctors don't think about endometriosis, but as you'll see later in the podcast, we're going to talk about complications of endometriosis, which can certainly be dangerous, which we need to know about. So again, Jennifer, how often are these truly flares versus delayed diagnoses versus complications? Can you give us some numbers?
Absolutely. So some studies, they've shown that the true inflammatory flares, which looks like a hormonal and prostaglandin-mediated disease activity, but has normal imaging in labs, is about 60 to 80% of the presentations to the emergency department. So this reflects people who have a known diagnosis of endometriosis and are coming in with these pain flares. And then another substantial percent, about 20 to 40%, are delayed or misdiagnoses. And in addition to what we just talked about, the long wait times for outpatient gynecologic care and additionally for subspecialty care, we know that the delay in diagnosis for endometriosis in Canada is about 7 to 10 years, and that on average, patients will see 10 to 12 physicians about their endometriosis before they'll receive a correct diagnosis. So those numbers are obviously staggering, and a lot of it stems from the dismissal and normalization of people's pain.
Delay to diagnosis is a decade or more.
And that was pre-pandemic.
That's incredible.
Yeah.
Wow. It makes me think, well, it must be really, really, really difficult to make the diagnosis. But I'm hoping that later we can talk about how it's actually not that difficult to make the diagnosis and save these people from literally decades of suffering. Wow. All right. And the other part of the question was the true complication rate of endometriosis. Could you give us a few numbers with that?
Yeah. So in one study, it's cited this 1 to 5% risk that someone's presenting with a true emergent complication. Certainly, these are considered more rare among people with endometriosis or endometriosis-like symptoms presenting to the emergency room. But these can include things like bowel obstruction, infected endometrioma, hemoperineum, ureteric obstruction, catamenial pneumothorax. So these are rare, but are certainly high risk if missed. And we can discuss these in a bit more detail.
Yeah, the pneumothorax one is fascinating. Can we just touch on that here before we move on? So you get endometriosis seeding into the chest cavity.
Correct.
So, Jennifer, could you just tell us a little bit more about that? How it presents, how it's discovered, how it's treated from an emergency point of view, when we might suspect it, etc.?
I would say that if you have a menstrual aged person who is presenting with recurrent pneumo or hematothorax, the first thing to ask them would be any correlation with your menstrual cycle. Is there a timing correlation with your menstrual cycle? Because that would be the first clue that if there's a timing with their menstrual cycle that's consistent in someone who's menstrual aged female with recurrent hemato or pneumothoraces, that starts to raise the alarm. Again, this is a very rare complication of endometriosis. But essentially, the endometriosis seeds on the diaphragm and then can go into the pleural cavity, leading to endometriosis in the pleural cavity. That leads to pneumothorax when people have their menses and have this flare-up of their endometriosis.
Fascinating.
We have an incredible case in CMAJ that describes a young woman who had every month hemoptysis.
Mm-hmm.
And it turned out that her monthly hemoptysis was from endometriosis, and it was because of the hematologic spread of the endometrioma into the lungs, which I just think is fascinating to think about, the many different organ systems that can be affected by endometriosis. So the bowels, the lungs, diaphragm, it's just remarkable.
I thought pelvic teratomas were the number one fascinating diagnosis in obstetrics and gynecology, but maybe this is a close number two, I would say.
Yeah.
I want to get back to our patients in the emergency department who present with recurrent severe pain. So, Catherine, we see a lot of patients with recurrent pain in the emergency department, and they have a whole variety of diagnoses. Sometimes we feel sort of powerless to help them because they come again and again and again with pain, and everything's been tried and we don't know what to do. How does this endometriosis population differ from other recurrent pain patients that we see?
I think with the endometriosis population, there are treatments that, if initiated, are incredibly effective. And those are beyond what we often give in the emergency department. So I see it as my role as an emergency department provider to exclude those dangerous pathologies as discussed earlier, but then to plant a seed. And what I mean by that is, I often won't make the diagnosis of endometriosis, but I will discuss it with the patient as a possibility, such that and so often patients are learning, doing a lot of their own education outside of their healthcare provider visits. And so to think and plant a seed of, is this pain cyclical? Can you keep a diary? Is this something that's happening on a regular basis? So starting those discussions with patients, because I have to say I am, as an emergency department provider who's only seen this patient once, loath to say, oh yes, absolutely, this 100% is endometriosis. And I think it's because I was biased by, when I went through training, I was told that we couldn't make the diagnosis of endometriosis without the patient having, a laparoscopy. So for most of my practice, in the back of my mind, I said, oh, really only a gynecologist can make this diagnosis, but clearly that has changed. And we need to adopt our practice to recognize that patients can be started on treatments like oral contraceptive pills, and that making the diagnosis is now seen as a lot easier than it was, 20 years ago.
Absolutely. It's funny you use the language plant the seed, because, endometriosis does sort of seed all over the pelvis, and now we know into the lungs as well.
Not intended.
So good choice of words, Catherine. A lot of these patients will come with recurrent pain, and a lot of patients that we see with recurrent pain, we sort of label them as chronic pain patients. And I think you can all guess where I'm going with this question. Jennifer, what are the risks when we label these visits as sort of just chronic pain?
Certainly, it can contribute to the delay in diagnosis, as we discussed. And there were a few things that Catherine just said that made me think about that delay in diagnosis too, which is that when patients are on their own for so long, they do start to become, managers of their own care and their own symptoms. And sometimes I think when patients present with chronic pain and they're advocating for themselves, obviously we can see that as challenging, right? We can see it as a challenge if they're asking us for things that we don't feel are either in our capacity to provide them or that we don't feel are safe to provide them, like opioids, for example. It can become difficult to navigate when we label patients as pain patients. It comes with a whole stigma around what that means. And it also comes with a hopelessness about not being able to help them. And I think all of those things contribute both to a difficult relationship and to the cycle of dismissal and delay in diagnosis.
We've mentioned a few times ovarian cysts, and I just want to clarify, there's cysts that can happen from endometriosis, and then there's a whole bunch of other different kind of cysts. And I can't remember back from my gynecology rotation 20 plus years ago, all the different kinds of cysts. But could you just give us sort of a brief overview of what kind of cysts that we find on imaging should tweak our suspicion for endometriosis?
Absolutely. So one of the things to highlight here is that when we talk about normal imaging, there's a few caveats. We were saying before that sometimes we see, normal imaging. And so I'll talk about things like simple follicular cysts. Okay. So simple follicular cysts, fluid-filled cysts, anechoic cysts that are small are typically not related to endometriosis, for example. So that would be a follicle that gets released at the end of ovulation. But I just want to highlight that even if someone has one of these, what we would call normal ultrasounds. So for example, the ultrasound only comments on a 1.5 centimeter left follicular cyst and nothing else, that at this point in time, Canadian imaging standards are not up to the point where we can reliably detect endometriosis on all ultrasound. So there are high quality imaging centers, high quality ultrasound centers where endometriosis mapping scans are done or soft markers of endometriosis are done. And this is typically not done in hospitals that are and in imaging centers that are available to the ED. So even when we're talking about normal imaging, it doesn't mean there's no endometriosis that actually even could be seen on that imaging if it had been done by a more highly skilled endometriosis ultrasound expert. And that having normal imaging doesn't exclude endometriosis. So that's just an important point about imaging.
Got it. So key point, normal ultrasound does not rule out endometriosis.
Correct.
And then in terms of if you do find, besides a follicular ovarian cyst, if you do find a cyst, any clues there?
So then there's the hemorrhagic cysts are the one that are highlighted in the stem, and certainly the main one that should raise alarm bells for possibility of endometriosis or endometriomas. Essentially, what happens when you get a diagnosis of a hemorrhagic cyst is the difference between a hemorrhagic cyst and an endometrioma is whether that hemorrhagic cyst resolves with time. And so the standard recommendation for a hemorrhagic cyst is to repeat that imaging in 8 to 12 weeks and assess for resolution. If a hemorrhagic cyst resolves in 8 to 12 weeks, it was a hemorrhagic cyst. If it doesn't, then it's an endometrioma. To dive just a little deeper into that, a hemorrhagic cyst can occur each time someone ovulates effectively because the ovum bursts through the ovarian tissue, and sometimes that can lead to a rupture of a small blood vessel, which can create a hemorrhagic cyst, typically common and asymptomatic. However, the appearance of a hemorrhagic cyst on ultrasound can be fairly similar to the appearance of an endometrioma based on the echogenicity of those two things. So if you have, for example, a 3 centimeter hemorrhagic cyst, I say that in quotations, but then you recheck in 8 to 12 weeks and it's still there, that is likely, in fact, an endometrioma that's been misdiagnosed. Again, highly specialized imaging, people can sometimes tell the difference, but that's one of the key features.
That seems like such a simple piece of knowledge for emergency doctors that is so important. So I'm just going to repeat that. So if you have a patient with a hemorrhagic cyst on ultrasound, that hemorrhagic cyst could be an endometrioma. And all you need to do is ensure that they have a repeat pelvic ultrasound in 8 to 12 weeks. And if that hemorrhagic cyst is no longer there, it's just a simple hemorrhagic cyst. And if it's still there, it's probably an endometrioma, and they probably have endometriosis.
You got it. And endometriomas are a sign of deep endometriosis. So people who have endometriomas, that is a big clue that they actually have deep endometriosis, which can have obviously significant impacts. And typically endometriomas are actually the only thing that we can find from endometriosis on most ultrasounds that are not done by specialty centers. So often people will come in, I've seen a patient like this, normal ultrasound, no more ultrasound, hemorrhagic cyst, oh, it's an endometrioma. They finally get that diagnosis. And by the time we see them, they have, advanced and deep endometriosis. They probably always had the endometriosis, but it took it getting to a point where they had grown a significant sized endometrioma for that diagnosis to be picked up on imaging.
Got it. Interesting. I mean, we all know that whoever's looking at an ultrasound, all of us have the exact same capability of picking up all kinds of things.
Of course.
I mean, it's the old age problem with ultrasound, is that it all depends on whoever's doing the ultrasound and their interpretation of it. Okay. And then with imaging, what about CT? From an emergency perspective, we use CT quite often in these patients with negative ultrasounds. If we're still worried about them, we might move on to a CT because maybe we're missing obstructive nephrolithiasis or something else. How about the value of CT after ultrasound in diagnosing endometriosis? Is there any value there?
Not particularly. MRI pelvis is more useful than CT. So we don't typically use CT in outpatient endometriosis care. MRI pelvis has a lot more value for us. As opposed to CT, we don't have as good diagnostic capabilities.
I want to back up a bit. Let's go back and talk specifically about historical features that predict endometriosis the best. Let's say in our heads, we've essentially ruled out ovarian torsion and other emergencies. What are some of the key historical features that we should be looking for so that we might actually be able to make the diagnosis of endometriosis in the emergency department and get these patients onto a good, solid path?
Yeah, one pattern that I've seen, and I've wanted to do this study for a long time, is I think most people who present with dysmenorrhea to the emergency department are already at high risk of having endometriosis. Because most people with primary dysmenorrhea, again, the knowledge is out there. People know to take acetaminophen. People know to take anti-inflammatories and to try and manage their own pain. And there's a lot of, cultural pressure to kind of tough out your period and to manage it yourself. So I think most people that get to the point that they've come to the ED with dysmenorrhea are already at high risk of having some kind of what we call secondary dysmenorrhea. So we differentiate primary dysmenorrhea is dysmenorrhea that has no pathologic underpinning. It's, somewhat physiologic pain that happens with the period due to the really strong uterine contraction and can typically be managed with first-line care, which is either hormones or anti-inflammatories. And secondary dysmenorrhea is something that has a pathologic underpinning. Endometriosis is probably the most common example, but other things like fibroids might apply as well. So again, people who are coming to the emergency department with dysmenorrhea have a pretty high risk, in my experience, of having a secondary cause of their dysmenorrhea. Other features would be if you see progressive worsening of dysmenorrhea over time, or if the patient has experienced a progressive worsening of their dysmenorrhea over time, and if they then start to develop intermenstrual pain. So one of the most common patterns I see is someone tells me, I've had bad periods, painful periods a long time, often starting in late adolescence, or even sometimes early adolescence, but early, mid, late adolescence. And they kept getting worse over time. And then the pain went from being only 1 or 2 days to being 4 or 5 days or 6 days. And now my pain is starting to stretch to half of the month. That's like the most common thing I hear. Now I have pain half the month, and then eventually it gets to be pain every single day. So that progressive worsening of pain over time is pretty classic of endometriosis. Missed school or work because of a period is actually not normal and is a common sign of endometriosis. Not responding to first-line therapy, anti-inflammatories and or hormonal therapies. And then there are other associated symptoms. So deep dyspareunia is common. Pain with bowel movements, and especially pain with bowel movements during the period, is a possibility. I think those are the main things.
In summary, you've got patients with dysmenorrhea who are already at high risk, and then there's progressive dysmenorrhea, and that pain sometimes progresses to outside of their menstrual period and can even become constant pain all the time. There's dyspareunia. They have these cyclical GI and GU symptoms. And then I suppose there's also infertility. And then I understand that also a family history of endometriosis, that it's partially genetic, is also a question you might want to think of asking in the emergency department.
Certainly. Yeah.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricate's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricade.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
Okay, let's go back to our patient, our 24-year-old with lifelong severe dysmenorrhea who presents with her third ED visit this year with 10 out of 10 pelvic pain and vomiting at the onset of menses. She's previously been labeled as a hemorrhagic ovarian cyst and lost to gynae follow-up. So her beta HCG comes back negative, her other labs are all negative, and her repeat ultrasound is reassuring, yet her pain remains severe. So let's talk about distinguishing emergent versus non-emergent presentation. So Catherine, what are the true red flags that suggest an acute, dangerous complication of endometriosis?
So for the clinical history, I mean, irrespective of endometriosis being your final diagnosis, the 10 out of 10 pain and having vomiting are two red flags for me in their clinical presentation. And then the lack of response to analgesia. So in this patient where they've been in a department for some time, presumably receiving analgesics and not having appropriate response, I probably would move on to doing CT imaging in this patient to look for not only the complications of endometriosis, but also other underlying pathologies. So thinking about a kidney stone or bowel obstruction, particularly in a patient with 10 out of 10 pain and vomiting. So that would be my next move in this patient. And we can talk more about some of the complications, but specific to endometriosis, bowel obstruction would be higher on my differential for this patient. A ureteric obstruction is also a complication, but it usually doesn't present in this acute way. It usually is a silent renal death, so to speak. And so I would think less about that, but still I think it's important in this patient to have imaging of the kidneys to make sure that there's no hydronephrosis.
Love that.
So it's interesting that, the differential diagnosis for someone who presents with acute severe pelvic pain includes endometriosis, and it includes things like bowel obstruction and ureteric obstruction. But that's interesting that some of the complications of endometriosis include bowel obstruction and ureteric obstruction. I've probably had multiple patients over the years with bowel obstruction or ureteric obstruction that I can't figure out why they have that. Maybe endometriosis was the cause in some of those cases. So let's move on to labs. If the labs are quite abnormal, not just like a little bit of an elevated white count or a little bit of an elevated CRP, but if you have significantly abnormal labs and you suspect endometriosis, that should really be a warning sign that there's a serious complication of endometriosis going on. And then also that normal labs are entirely compatible with a severe endometriosis flare.
Yeah, and I think this would be a great time to talk about PID briefly as well. As we know, the diagnostic criteria for PID are broad and appropriately so, but cervical motion tenderness, you're going to find cervical motion tenderness on pretty much any patient who's having pelvic pain, just to say that right off the bat, because they're having pain probably on their entire pelvic exam, and it can be hard to distinguish what's actually cervical motion tenderness from pelvic tenderness on exam. Similarly, when the white blood cell count is a little bit elevated or the CRP is a little bit elevated, I often see people who are given this diagnosis, well, they have pelvic pain and a slight white count, they must have PID. And I've seen that cause harm in some circumstances where, for example, I had a patient who had very severe endometriosis and had a large endometrioma that ruptured, and this diagnosis of PID carried with her for weeks during her care. And she was on antibiotic therapy that was almost certainly unindicated for weeks during her care because no one could let go of that diagnosis. Everyone was then afraid of being the person who stopped the antibiotics and let her infection take over when she, I'm certain, never had an infection. So just sometimes it's helpful to say possible PID or suspected PID, especially when passing on that referral to or passing on that consult to a specialist, and just being cautious about how often we give people a diagnosis of PID when they present with pelvic pain. Although, again, it's obviously important to think of that on the differential. I welcome your thoughts on that too, because I know it's a tricky one.
Yeah, that's really interesting because There is a school of thought out there that we should really have a very low threshold to suspect PID and treat for PID from the emergency department. And I find myself giving a lot of antibiotic kits to patients who I don't really suspect have PID, but I'm doing what I'm told I should be doing for pelvic pain. Yeah, let's maybe dig into that a little bit further. Any clinical clues or pearls that you can give us to help distinguish PID from endometriosis besides what we've already talked about?
And I know you have, I think together you've done a podcast on PID as well. So hopefully your listeners can listen to that for some good clues as well, because it's such an important diagnosis. But I would say, especially on someone's first time presentation, acute pelvic pain, have to think of PID for sure. But trying to be clear in your documentation of what your diagnostic criteria were to make that diagnosis can be helpful. Even if you, document suspected PID based on this criteria, could be something else, will provide antibiotics, to be cautious. I think that's helpful that if the patient represents and it says, suspected PID instead of definitive PID, and the findings were, for example, cervical motion tenderness and pelvic pain, then the next provider hopefully can use their judgment and go, well, this is looking more like chronic pain perhaps, and there's never been something that was slam dunk for PID, as opposed to, the PID patient who comes in and has purulent discharge, plus or minus chlamydia, plus or minus gonorrhea, that's like pretty slam dunk. And so being really definitive about, this is a very definitive PID that I have a lot of good diagnostic criteria, or this is a treat to not miss kind of PID. If in the documentation that can help hopefully future providers, rather than just diagnosing recurrent PID in someone who's actually presenting with recurrent pain. Or if you see someone who's been diagnosed with PID multiple times without significant risk factors, and looking back on those findings and go, did they ever have a really clear diagnosis? Maybe I need to stop this cycle of diagnosing them with recurrent PID.
Yeah, diagnostic momentum can be very powerful.
Yeah.
So you need sort of a cognitive forcing strategy to tell yourself, okay, whenever I see a diagnosis of PID, question whether that truly was PID and, look for evidence for it in the chart.
And I think this conversation gives us a chance to talk about doing pelvic exams, for this patient population, but for patients with pelvic pain in general, because it does give us information that's important, particularly for providers in follow-up, to know whether or not there was purulent discharge, to also see if there are findings of endometriosis on the vaginal exam or in the cervix. And I think we underutilize pelvic exam because there have been some poorly done small trials that said that they weren't particularly effective at, making the diagnosis of, assisting the diagnosis of pelvic pain in the emergency department. But I do think increasingly we're underutilizing pelvic exams to assist with our sort of diagnostic process with these patients, and sort of potentially mislabeling them as having PID or something else.
So let's talk about evidence-informed ED pain management a little bit. And when it comes to endometriosis, we're going to treat these patients just like we treat anyone else with pain. We're going to give them multimodal analgesia. We're going to avoid opioids when possible in terms of giving them a prescription for home, because we all know that the opioid pandemic continues. My understanding is that there is some evidence that oral contraceptives and progestins, which are first-line therapy for endometriosis, actually significantly help their pain. And this is a controversial topic in terms of what role emergency physicians have in terms of prescribing long-term medications. So some of us are okay with prescribing, let's say, antihypertensives to a patient, which is a long-term treatment. Some of us are not. Some of us are okay with starting someone on an antidepressant. Others are not. And this kind of depends on how you define emergency medicine and what our role is, and is going to be different in different geographic locations. My approach to this would be, if I've exhausted all the other usual analgesics in a patient with endometriosis, and I suspect that they might bounce back to the emergency department with pain again, I would want to try and start them on an oral contraceptive. And if I don't know enough about the oral contraceptives, and especially if it's banking hours, I may just call the gynecologist on call and ask them, hey, would it be okay to start them on an oral contraceptive? And if so, which one? Jen, what's your take on starting oral contraceptives for patients with endometriosis pain from the emergency department?
Yeah, and I think that as a specialist and subspecialist, it's certainly not my expectation that an emergency physician would do that compared to a family physician who I absolutely would expect to at least offer their patient hormonal management before they would come to see me as first-line therapy. But absolutely, both progestins and combined hormonal contraceptives, including the oral contraceptive pill, are first-line treatment for endometriosis. And I really feel that in the absence of contraindications, anybody could start those therapies if they wanted to. I know there are about 1 million contraindications to the oral contraceptive pill or combined hormonal contraceptives, which can make it a bit daunting to prescribe. So I want to talk about those, but I want to make a really brief plug for progestin-only pills. So progestin-only contraceptive pills or non-contraceptive pills, because these are super safe medications to the point that there is some discussion about trying to make them available over the counter for people to have increased access to contraceptives without having to see a physician. And so for one example of a pill that gets used frequently is drospirenone, or the brand name is Slind, progestin-only contraceptive pill. Super safe. Contraindications would be, for example, breast cancer, a personal, not family history, personal history of breast cancer, severe liver disease, and current pregnancy. That's basically it. You will see, if you looked at the contraindications, it'll also say undiagnosed abnormal vaginal bleeding. The idea is not to miss, for example, a major, like a cancer or something like that, that's going undiagnosed. And again, that's where the role of having them have outpatient care from a gynecologist or the family physician is important. But for someone who has regular menses, no personal history of breast cancer, no severe liver disease, it is super, super safe to give someone a progestin-only pill. So again, I would, as far as simplicity goes, Slind is a brand name pill. You can write it Slind, 1 tab, PO daily. That's the prescription. You can give someone 3 months. You can give them 3 repeats. That gives them a year supply of this medication. It is also a reliable contraceptive. So that's kind of one safe and easy starting medication that I could recommend. As far as the oral contraceptive pill goes, also a first-line therapy, although I think there's a gradual movement in the endometriosis community toward progestin-only pills for reasons which I won't necessarily get into on the podcast, but combined hormonal contraceptives like the oral contraceptive pill are also a great option for first-line therapy. My quick and easy approach to prescribing OCPs is, first of all, knowing their medical history, making sure that you've asked their medical history. So anything that alarm bells, like a history of breast cancer, a history of any kind of gynae cancer, a history of, not all gynae cancers are contraindications, but those are kind of things that would make you think at least or call the gynecologist. A history of severe liver disease, those usually would come up on the past medical history. So I think if you've asked the patient their past medical history, you get many of those key features that are on that contraindication list. The things I ask people specifically because I don't want to miss them or they might not mention it: do you have a history of a blood clot in your lungs or your legs? Now I'm using my patient lingo, but do you have a history of a blood clot in your lungs and your legs? Do you have a history of migraines? If so, do you have auras? So those are 2 main contraindications: history of VTE, migraine with aura. Do you smoke? Which is relevant for people 35 and older. And then looking for hypertension in the past medical history. If you can rule out those 4 things, so VTE, migraine with aura, smoking over age 35, and making sure that their blood pressure is normal that day, if you've reviewed their past medical history, you are probably safe to start on an oral contraceptive pill. You can use any oral contraceptive pill. Using continuous use oral contraceptive pill, really helpful, because that means people are skipping their period, so they're skipping their placebo pill so they don't get a period. The other thing that I look for in a formulation is something called monophasic pills. So that means they're getting the same amount of hormone in the pill every day, as opposed to triphasic pills, which have a different amount of hormone each week of the pill pack. So monophasic pills, can use them continuously, but honestly, any OCP would be fine. You can't go wrong to start.
Got it. Okay, so just to review there, we do have the option, depending on your philosophy of what your role is in as an emergency physician, but we do have the option of prescribing progestin-only pills to patients. And again, this would be 4 milligrams of drospirenone, which the brand name is Slind, and that would be 1 tablet daily. And we'll have all those details in the show notes. And the contraindications are breast cancer, severe liver disease, and current pregnancy. And then if you choose to provide the patient with OCP, use a monophasic pill, you can consider continuous use. And the contraindications there are migraines with aura, any thromboembolic disease, hypertension, and smoking.
Yeah, smoking for people age 35 and older. And I would, if you want more detail on all of the list of contraindications, there's a great app, the MEC app, Medical Eligibility for Contraceptives app, or you can look up WHO MEC contraindications. So that's some quick and easy ways.
Okay. The MEC app. And that's not Mountain Equipment Co-op, which if you're Canadian and you're an emergency physician, most of us are outdoors people. This is a different MEC. Can you give us a general sense of what the best evidence-based treatment options are for these patients so that at least we can counsel them before we discharge them? It's like, well, you're having me see a gynecologist. Why are you having me see a gynecologist? So what can I tell patients in terms of counseling them about what might happen when they do see you and follow up?
Yeah, so you could definitely tell them that we'll discuss medical therapy. You could say medical therapy because the word hormone can be so loaded for some people. So medications that you can use to manage your endometriosis, and they may discuss surgery with you for endometriosis. That's probably the helpful one-liner.
And for minimally invasive surgery, how has the treatment for endometriosis evolved over the last 20 years?
Thank goodness it has evolved a lot. I think endometriosis is really where some of the need for our subspecialty developed, was to be able to provide this better quality, complex surgical care for endometriosis patients, because it's a very complex surgery. It's really difficult. And where we used to talk, about ablation, as you said, we've really moved mostly towards excision surgery, although there's still a role for ablation surgery that I could do a whole podcast on that. But excision surgery is probably the more common thing that's offered now. And as you mentioned at some point earlier in the podcast, that, we could talk about the diagnosis of endometriosis, that it doesn't have to be surgical. So not every endometriosis patient will be offered surgery. And I think one thing that's different from 15, 20 years ago is patients used to have like a lot of repeat laparoscopies. Like, you see patients who'd had a laparoscopy every year. They had 12 laparoscopies. That's no longer really the trend. Ideally, patients should be having 1 to 2 surgeries for endometriosis if necessary, 0 to 2 surgeries for endometriosis in their lifetime. There's obviously a lot of caveats to that statement, but the days of a surgery every year, 12 surgeries are more or less gone. And the level of surgical care that's required depends on the extent of the disease.
Could you just tell us a little bit about the outcomes from the medical therapy and from the surgical therapy? I mean, this might be something we might want to, our patients might ask us about in the emergency department. So just a general sense of how good or not good the medical therapy is and the surgical therapy is for endometriosis.
It depends on whether they're having dysmenorrhea or whether they've evolved to that chronic pelvic pain, which often involves things like central sensitization and myofascial pain. It depends on what they've tried before and what their responses have been with side effects and benefits. And it depends on whether they're seeking fertility. So there are a few different things that will impact how effective medical therapy will be. I think one thing you could say to patients is, the specialist will ask you, hopefully, about your fertility plans. That's pretty much a guarantee. They'll ask about their fertility plans. You could say this specialist would be happy to discuss with you what you've tried before and what the results have been so that they can find something that will help you. Because a lot of people will come to me and say, I've tried all the pills. I've tried them all, and I don't want you to give me another one. But what they mean is I've tried 8 different oral contraceptive pills, combined hormonal therapy, and I haven't tried an IUD. I haven't tried a progestin. I haven't tried Myfimbri. I haven't tried a lot of other options that we have now. You could mention that there are new medications, like within the last 2 to 3 years, that have come out that we can offer. So overall, I'd say medical therapy can be really effective for some people. And for those for whom it isn't, they can be on a path to possible surgical therapy and multidisciplinary care for their chronic pain, if that's what's plaguing them.
Got it. Okay. So very complicated. There is hope for these patients, however.
Yes.
And ideally, we want to get them to an endometriosis specialist. One last question, Jennifer. When we do write that referral to you, what do you want to see on the referral?
If there is imaging evidence of endometriosis, including that is helpful, there are a variety of endometriosis providers. Some providers will only see people with, for example, imaging evidence of endometriosis. They consider themselves a surgical endometriosis expert, and that's all they're going to see. Other providers are more willing to see also chronic pain, even if there is not a diagnosis of endometriosis. So you'll help your patient find the right provider for them by indicating if there is or is not imaging evidence of endometriosis, what the main symptom is, for example, dysmenorrhea versus chronic constant daily pain, and if there are any red flags. So that would be things like if they did present with a bowel obstruction, they're probably going to be seen in hospital, but if they did present with hydronephrosis, that's going to be informative. I think that hydronephrosis in the setting of endometriosis is very concerning. Because it signals that there is such ureteric involvement as to cause ureteric partial obstruction and hydronephrosis. So I think that deserves an urgent consultation. As an outpatient would still be appropriate, but urgent outpatient consultation, absolutely. Because the creatinine is often normal for a long time and then suddenly not normal, and then suddenly the kidney is lost.
Before we go back to the case and wrap up, in terms of disposition, those patients who you're worried about and have a complication of endometriosis that we've talked about in the podcast so far, I imagine those patients need a consult in the emergency department to gynecology. Could you just give us a sense of when we might consider a gynecologic consultation in the emergency department for patients who present with endometriosis flares?
I would say the patient who can't be sent home because you absolutely cannot manage their pain. That's probably the most common reason I see people admitted with their endometriosis or refractory vomiting related to their pain. The other people who need to be consulted in the emergency room, an infected endometrioma is a medical and surgical emergency. So an infected endometrioma, definitely. A ruptured endometrioma is often an appropriate consult in the emergency room. So if you have evidence of a previous endometrioma, for example, a patient with a known 9-centimeter endometrioma, they come in with severe pain, unlike an episode they've had prior, free fluid in the abdomen. Those patients often require at least admission, if not surgery. And then the bowel obstruction, which is rare, but the bowel obstruction patient would be the other patient. I think those are the main ones to look out for.
Fantastic. All right. What would your take-home message be to emergency providers about endometriosis?
A lot of it's sort of that it's how you are at the bedside. Like I know from my clinical experience that patients really appreciate being heard, being listened to, being properly examined, having a pelvic exam where appropriate. And so often they'll tell me that they have not had a pelvic exam. No one has offered to do, an ultrasound. They've sort of been written off through their healthcare experiences. And, part of our job is in these emergency situations where these patients are having a lot of pain is to validate that they're in pain, to do an appropriate physical exam and a thorough physical exam. And then through the course of, which these are long visits in the emergency department, and when you are receiving your imaging results, going back to the bedside, reassessing their pain, and then talking about what's going to be their next steps in their journey. And I think that's the part that we as emergency department providers often miss, that is particularly relevant to patients with endometriosis, because we are planting that seed that this is not inexplicable pelvic pain, that there is likely a diagnosis of endometriosis. You need appropriate follow-up. You need appropriate treatment. It's most often not going to just be ibuprofen, and they're likely going to need oral contraceptive pill or progestin to help with their symptoms. And I think that final touch point in the emergency department visit is critically important for this patient population.
We will have a link to a toolkit that's been designed specifically for emergency doctors to help manage patients with endometriosis. That'll be in the show notes. Well, this topic is one that many emergency providers know little about, and I personally feel like I've learned a ton from this podcast. Acute pelvic pain still means rule out the time-critical stuff first, like ectopic pregnancy, ovarian torsion. But when the story fits, that cyclic pain that's getting worse and worse, if they have bowel or bladder symptoms with their menses, if they have terrible dyspareunia, these are kind of the things that should tweak you to thinking maybe this is endometriosis and get them on the right path. So until next time, recognize it, treat it, and connect your patients with the care that they need.